Hey class, welcome to uh, bone and osseous tissue, which is week 5 in a 15-week class, second half of week 3 in a 12-week class. So we're covering, I believe it is chapter 5. So our skeletal system includes our bones. That's what most people think of when you think of the skeleton, but it also includes all of our cartilage, our ligaments, which connect bones together, and then many other connective tissues. Functions are to support the weight of the body, store minerals, namely calcium is the main mineral, but there are also phosphorus, magnesium, other minerals within bone, storage of lipids in yellow marrow, blood cell production in red marrow. That's one that many people forget about when thinking about functions of the skeleton is blood cell production. Protection, our rib cage and our pelvis give protection of our important internal organs. And then leverage, so they are a lever in which muscles can pull on bones to move the skeleton through space. We classify bones in multiple different ways, one of which is by the shape of the bone. We also can classify by the way that the bone tissue is organized inside the bone or within the bone, and then by certain markings on the external surfaces of the bones. So we're going to look at different ways that we can classify bones. So we'll start with bone shape. The first shape is the long bone. So long bones are long and thin. You see a long bone right here. They're found in the arms, legs, hands, feet, fingers, and toes. So they're longer than they are wide. So the humerus in the upper arm, the radius and ulna in the forearm, but also the fingers and the bones in the fingers and the toes. So if you look down here, this is showing you carpal bones, which are short bones, but these are the metacarpal bones here, and they're all long bones. Even though they're in the hand, they are longer than they are wide, which is what makes them long bones. So we'll delete that. Flat bones are thin and they have parallel surfaces. So the surfaces of the bone are parallel to one another. We find these in the ribs, the sternum, the skull, and the shoulder blades or scapula. So here we have a flat bone, which are, this is in the skull, the parietal bone. So they are very flat and have parallel surfaces to one another. Sutural bones found here are little tiny bones that are found in the sutures of the skull. So the sutures are formed where two different flat bones that make up the skull come together. So on this picture you can see a suture here, and then a suture there, and a suture here. And this little bone right there that's within that suture is called a sutural bone. Sutural bones are called a normal variant, which means some people have sutural bones and other people do not. So it's something that it occurs, and so we like to know what it is, but it's not everybody has a sutural bone, and it doesn't really make any difference if you do or if you don't. It just makes you slightly special. So sutural bones are only found in the skull, and they are found along the lines of the suture where two of the skull bones come together. Next we have irregular bones. So over here is an irregular bone. This is a vertebrae. And irregular bones have a shape that's complex. They don't fit into any other category. They're not flat, they don't have parallel surfaces, they're not short, so they have kind of an odd shape. So our vertebrae are an example of an irregular bone. The pelvic bones are also irregular bones, the coxal bones, and we'll look at those the week after next. We're going to look at the coxal bone. So for this week, we're going to look at the vertebrae as an irregular bone. Then we move on to our short bones. So here we've got short bones. So our carpals, the bones that make up our wrist, and our tarsals, which are the short bones that make up our ankles and the top of our foot, those are short bones. So they're small and thick, and so they're just very small little bones. So in the wrist and the ankle is where we find our short bones. And then last we have sesamoid bones, which we see here. Sesamoid bones are small and flat, and they develop within a tendon. So the patella, which is what we see here, which is the fancy name for the kneecap, the patella is the main sesamoid bone in the body. Pretty much everybody has one. But it develops within the quadriceps tendon. You can also develop small sesamoid bones in the tendons of your hands and your feet, and those again are normal variants. So pretty much everybody has a patella, but as far as sesamoid bones in your hands and your feet, some people are going to have them, other people are not, and it doesn't really make that much of a difference. So knowing that the patella is the main sesamoid bone is going to be helpful for you. They are called sesamoid bones. They look like little sesame seeds. So the patella is a large sesamoid bone, but the rest of them are much smaller and sort of the shape of a little sesame seed. So we also want to look at different markings on the outsides of bones. So a depression or a groove is just like it sounds, a groove along the surface of a bone. And so that might be where an artery runs or where a nerve lies or where a tendon lies, and it forms a little depression within the bone. A projection is something that projects or sort of comes off of a bone, and these are usually where tendons and ligaments attach. So where that ligament is or tendon is pulling on the bone, it attaches to the bone and it's pulling, the bone's response is to lay down more bone. And so over time, when you have that pulling of the tendon on the bone, you're going to get a larger projection. Larger muscles are going to create larger projections on bones. So we'll find large ones on the femur, which is just below the hip, because you have those big hip muscles, the gluteus muscles and things pulling on that area of the femur and creating these larger projections, which are called trochanters. And then we have smaller projections on smaller bones where we have smaller muscles attaching. Tunnels or openings in bones are where blood vessels and nerves enter a bone. We see a lot of these within the skull. And so for this week, we're just looking at trying to define what these different markings are called, so that over the next 2 weeks when we're learning specifics, we don't have to go into the basics of, okay, this is a hole in a bone, what's it called? It's like, okay, well, we know that that's a meatus, and so we could name that more specifically. So just an overview this week. So this slide, I want you to come back to and look at, make sure that you can identify all of these things on a bone. And you'll see some of this in your lab/homework this week on learning to identify all of these things. So a process and a ramus are projections off of a bone. A ramus, you want to know, makes an angle with the rest of the structure of the bone. So I'm going to show you some examples in the coming slides, but just to point out that a process is just a projection or a bump off a bone, but a ramus is an extension of a bone that makes an angle with the rest of the bone. So we'll see ramus on the coxal bone in the hip, and we'll see a ramus on the mandible as well. Processes that form where tendons or ligaments attach. So there's a lot of these. So when you have tendons and ligaments attaching, they pull on the bone, creating increased bone deposition, and so you get these projections. So a trochanter is a very large, rough projection, and we see those on the proximal femur. So remember, proximal means closer to the attachment to the body. So the trochanter is on the proximal femur. A tuberosity is similar to a trochanter, but it's smaller, so it's a small, rough projection. A tubercle is a small, rounded projection, so it's more smooth and less rough. A crest is a prominent ridge. Main one that we see is the iliac crest, which is along the top of the coxal bone. A line is a lower ridge, and we can see a line inside the coxal bone as well. And then a spine is a narrow or pointed process, and we'll see some of those in the coxal bones as well. And again, I'm going to point these out in pictures in the coming slides. Process is formed for articulation with adjacent bones. So articulation is the fancy word for a joint. So where two bones come together, we have processes that are involved in those regions. So if we're looking at where two bones come together, the head is the articulating end of a long bone traditionally. And then, so it's an expanded area. And then below the head, you have a restricted area called the neck. And you can think of that like your head and your neck, right? Your head is larger than your neck. A condyle is a smooth, rounded articular process. We have condyles on the end of the femur, at the knee, and at the elbow, and the end of the humerus. A trochlea is a small grooved articular process that's shaped like a pulley. And so the trochlea, we have a trochlea on the distal humerus where the ulna comes and articulates with the humerus at the elbow. And then a facet is a small flat articular surface. So where two bones come together at a flat surface, we have facet joints between our vertebrae and the spine. And then there are facets on the back of the patella, where the patella is going to be in contact with the femur. So multiple different facets throughout the body. When we look at depressions, which we know are like a groove in the bone, a fossa is a shallow depression, and a sulcus is a narrow groove. So a fossa is shallow, but it's sort of larger. It's a larger area. The iliac fossa is the inside of the pelvic bones or the coxal bone. So that inner but posterior bony surface of the pelvis. And then a sulcus is a narrow groove. We have a sulcus on the top of the humerus where the biceps tendon lies and comes over the top of the humerus. There's a sulcus right there. And then last we have openings. So openings in a bone are passageways. So a foramen is a passageway for a blood vessel or a nerve. A canal or a meatus is a passageway through a bone that does not contain a blood vessel or a nerve. So a foramen has blood vessels and nerves. A canal or a meatus is just an open passageway through the bone. So in the skull, we have the ears that are passageways into the interior of the skull, and so those are considered a meatus, whereas the foramen are all the different holes where our nerves and blood vessels are entering and exiting our skull. A fissure is an elongated cleft. We'll be able to see a fissure in the back of the eye socket. And then a sinus or an antrum is an open chamber within the bone that's full of air. And sinuses work to decrease the weight of the bone, and they act for resonance of sound and air through the bone in the skull, and to help with creating your voice. And when you have a sinus infection, you end up with mucus in those normally air-filled spaces, and that can change your voice and cause pain and pressure within the bone. So here we have some pictures. So we're going to look at what we were just discussing in pictures. So this bone on the left here is the femur. So the femur goes from your hip to your knee. You can tell the femur because it has this large head projecting off at an angle from the shaft of the body, versus the humerus, which is also a long bone, but it's much smaller than the femur. This is the upper bone in the arm, And you can see how the head is just kind of attached into the bone here, and it's not projecting off at this angle like the head of the femur. So I just wanted to point out the differences between the femur and the humerus. That's something that you're going to want to become familiar with, how to tell the different bones apart from one another. So when we're looking at the femur, here we have trochanters. So those are roughened large projections off the bone. On the femur, we have this larger one on the outside is the greater trochanter, and on the inside is the lesser trochanter. We'll do those in 2 weeks when we do appendicular skeleton, but I like to just throw some terms out there now so that we can, some of the new material in a couple weeks is going to feel more like review. And then you see this rounded head here, and then this constricted area right below the head, which is the neck. So the head is the rounded articular part that fits into the socket of the hip, which it actually fits in right here to the socket. And then the neck is this constricted part below the head. So this is the proximal part of the bone. On the distal part of the bone, there's a tubercle shown here, which is a smaller rounded projection, and that is up above the knee. There's a facet here for articulation with the patella, and then the condyles are the two rounded articulating surfaces on the bottom that are going to go and sit on top of the tibia. All right, we'll look at the skull next. So with the skull, you can see the sinuses are those open air-filled chambers within the bone. And you can see there's many of them. So these are the frontal sinuses, the maxillary sinuses. We've got ethmoid sinuses in there. So there are all kind of different sinuses that we'll learn about next week. You can see a foramen above the eye here. There's a little hole that goes through the bone. That's a foramen. Some people have a foramen there, and some people have a notch, so it's not a complete enclosed hole. You can see the fissure. So in the back of the eye, there's, let me see if I can do this in a different color. This elongated, you can see where my red is right there. That elongated black opening is a fissure. The process over here they're showing you is an elongation of a bone that is coming off of the cheekbone and heading back toward the temporal bone on the side of the skull. What else do we have here? Canal. So the canal is hard to see, but it's basically just a round opening within the back of the eye socket. On the humerus, there's a head and a neck, which you can see this whole thing is the head, and then the neck is down here. We're going to learn about the surgical neck and the anatomical neck when we do appendicular skeleton in 2 weeks, ideally with some better pictures. Here's that sulcus I was talking about. This is the groove where the biceps tendon lays. So that's a sulcus, where it's just a groove in the bone where that tendon is going to lay right in there. Tubercle, this is a rounded projection. This tubercle on the edge of this would be the lateral side of the humerus. So right now, all of this is at the shoulder that I'm showing you. Here we have a tuberosity. This is the deltoid tuberosity. So it's where your large deltoid muscle comes down and attaches into the shaft of the humerus. That is the deltoid tuberosity. So that's sort of a large roughened area where that muscle attaches. And then down at the distal humerus, we've got a fossa, which is a like an indent in the bone, and that fossa is where the lip of the ulna is going to come and sort of recess into that bone when you are flexing and extending your elbow. And then the trochlea which you can see right here is that pulley-shaped articulating process there that where the humerus and the ulna are going to glide upon one another at the elbow joint. And then over here is the coxal bone. This is part of the pelvis. So we've got the iliac crest. So the crest is this part up here, which is just a prominent ridge on a bone. This whole area here is called the iliac fossa. So that is an indentation in the bone. The spine here, you can see this sort of sharp process. That's the anterior superior iliac spine, and then this is the anterior inferior iliac spine. So anytime you've got that sharper process coming off the bone, that is considered a spine. And then the ramus here, you can see a ramus. And the ramus is where, remember, part of the bone comes off of the other bone at an angle. So this is a ramus here, and this is a ramus here. So these are parts of bone that are coming off of this main bone at an angle. And last, we have a line. So this ridge here is a line. So it's sort of where this part of the bone comes to an edge and then it kind of angles and goes down again. So it makes this prominent line. So right there is considered a line. Next, we're going to look at the structure of a long bone. So here it's showing us the femur, but every long bone has the same general pieces and parts. So that's what we're going to look at now. So the bones have articular cartilage, which is hyaline cartilage at the ends of the bone. So where the bones come together and make joints with other bones. So on this bone, the cartilage would be around the head here, and then on the condyles down here. So that would be your articular cartilage, because the top part at the head is coming together with the acetabulum, or the socket of the pelvic bone, and down here the condyles are articulating with the condyles of the tibia. So you've got hyaline cartilage that are covering those to decrease the friction between bones where they come together at joints. The diaphysis of a long bone is the shaft. So this whole region here is the diaphysis. The diaphysis has a large wall of compact bone which surrounds the central medullary cavity. So you can see, let's see if we can do a different color. So you can see where it's very white in here, this is compact bone there. And then that darker center is a medullary cavity. So it's an open cavity where the bone marrow is. And there's some sort of spongy bone in there. But we have compact bone on the outside. So it's very hard and resists stresses that are put upon it through holding up the weight of your body. So the shaft is the diaphysis is the shaft of the long bone. It has that wall of dense compact bone surrounding a central medullary or marrow cavity. Next we have the epiphysis. So the epiphyses are the either end of the bone, so the articulating ends. So on this bone we have two epiphyses, and you will always have two epiphyses in a long bone. So you're going to have one diaphysis, two epiphyses, and two metaphyses when you're looking at a long bone. So the diaphysis is the shaft, and then the epiphysis is going to be the ends. So we have a proximal end up here and a distal end down here. And so those are the epiphyses. They are widened. They are the areas that articulate with other bones, and they're mostly made up of spongy bone. And spongy bone is going to resist stresses in multiple directions and lighten the weight of the bone. So spongy bone is very important. It is, and then it's covered by a little cortex of compact bone. So it still has the strength of the compact bone, but then the spongy bone lightens the weight of the bone and helps to resist stresses in multiple directions. And then last we have the metaphysis, and the metaphysis is the area where the epiphysis and the diaphysis meet. And this is where the growth of our bones happens, and it's what gives us what are called our growth plates. So when you're young and you take an x-ray of a bone, we'll look at these later, you have these dark lines in the bone where it looks like the pieces of bone are not connected, and those are at the metaphyses. So the metaphysis is where the epiphysis and the diaphysis come together. So when you're looking at a long bone, starting up at the top, you have the epiphysis, and then the metaphysis, and then the diaphysis here. Let's see, we'll do the epiphysis in purple. How's that? So we have the epiphysis, and then the metaphysis, and then that red diaphysis, and then another metaphysis, and then the distal epiphysis. Say that 3 times fast. All right, so epiphysis, metaphysis, diaphysis, metaphysis, epiphysis. So those are the different regions of a long bone. The diaphysis is mostly compact bone with that central marrow cavity. The epiphyses are mostly spongy bone with a thin covering of cortical bone or compact bone. Flat bones are structured differently than long bones. So our flat bones, like the parietal bone, which we're looking at here in the skull, are like a sandwich of spongy bone. So they have this cortical bone on either side. And remember, flat bones have 2 surfaces that are parallel to one another. So those parallel surfaces are made up of compact bone or cortical bone. And then the central area in between is made up of spongy bone or trabecular bone. So we have 2 layers of compact bone, and sandwiched between them is spongy bone. In the skull, that spongy bone has its own name, which is diploe or diplo. I don't like the pronunciation of that word, so it's diploe, I believe, is how you actually pronounce it, but that is the name for the spongy bone within the skull only. So when you're looking at, say, the sternum or the scapula, which are flat bones, you don't call it diploe, you only call it that in the skull. So we're going to talk about osseous tissue or bone tissue right now in some more general terms. So bone or osseous tissue is dense, supportive connective tissue. So we learned about that when we did tissues in a while ago. So bone tissue contains specialized cells, as do all tissues. They have cells that are specific to their own tissue. Produces a solid matrix of calcium salt deposits. So that's different. Osseous tissue is different from other tissues in that it is very solid. And then the calcium salts are wrapped around collagen fibers. So there are still a lot of collagen fibers. It's about 1/3 collagen fibers and 2/3 calcium salt deposits is what makes up bone. The dense matrix of bone contains calcium salts, and these cells are osteocytes, which are bone cells that live within a lacuna, and they're organized around blood vessels. So remember, the lacuna is an opening. We saw when we did tissues that cartilage has chondrocytes that live in a lacuna. So bone tissue has osteocytes that live in a lacuna. We're going to learn about other bone cells as well, but the osteocytes are the sort of mature bone cells that maintain the bony matrix, and they live within the lacuna. Canaliculi are little passageways that allow for blood vessels and then also for the extensions of the osteocytes to reach out and connect with other osteocytes at gap junctions. So remember, gap junctions are those connections where the rapid exchange of ions and nutrients can occur. So osteocytes are actually interchanging nutrients and substances with other osteocytes by reaching out their cytoplasmic extensions through these canaliculi. I will let you know that canaliculi is one of my favorite words, so it does often end up on quizzes and exams. The periosteum is the outer covering of the bone, so it covers the outer surface of the bone, and it has two layers. It has a fibrous outer layer, which connects the bone into the other tissues around it, and then an intercellular layer, which is active in bone growth and repair. Bone tissue is made up of minerals and proteins. The minerals make up about 2/3 of the bone, and it's mostly hydroxyapatite, which is the combination of calcium phosphate and calcium hydroxide. So just know that the mineral matrix of bone is mainly hydroxyapatite crystals. And then the proteins are made up of collagen fibers, and the collagen makes up about 1/3. So we have 2/3 are calcium and mineral deposits, and 1/3 of bone are collagen proteins. We have 4 different types of cells that we're going to look at in depth when we're talking about bone. So we talked a little bit about osteocytes. So here's a picture of an osteocyte. You can see that it is living in this little lacuna. So this is a space within the bone. And then it has all of these little extensions that come off of it in these canaliculi. And so those canaliculi are reaching out to connect one osteocyte to another osteocyte, or actually one osteocyte to many other osteocytes. These are the mature bone cells that maintain the bony matrix. The second type of cell is the osteoblast, so that's here. The osteoblast is an immature bone cell that secretes osteoid. This is osteoid here, which is the organic components of the matrix of the bone. So the osteoblast is building bone. Anytime you see blast, you want to think of building. So osteoblast is our bone building cell. Next, we have the osteoprogenitor cell, and these are large cells, and they divide to produce additional osteoblasts. So our osteoprogenitor cells are large cells that divide to produce additional osteoblasts. And then last we have our osteoclast. Osteoclasts are large multinucleate cells. You can see how these cells here each have one large nucleus, but this osteoclast has many nucleus inside of it, and the osteoclast secretes acids that break down bone. So osteoblasts are building bone and osteoclasts are breaking down bone, and they always work, or they should always work, at about the same level. So we're always building bone and breaking down bone at about the same rate. But this is always going on. Your bones are always being built and broken down and remodeled every day. So we're going to look a little bit more in depth at each of these bone cells. One of the things that I wanted to point out is that the cells themselves only make up 2% of the bone. So 2% of the weight of the bone is made up of cells. The other 98% is made up of calcium salts and the collagen fibers. So I'm not sure if that's in your book, but it tends to show up on quizzes and people tend to get it wrong because they don't always listen to what I say. So there's a tidbit. If you're watching my lecture, you have a bit of a leg up on the quiz or the midterm. It'll show up somewhere. All right, so osteocytes are the mature bone cells that maintain the bone matrix. They are the cells that live within a lacuna, and they are organized in layers or lamellae around the canals that house the blood vessels. They connect to one another by cytoplasmic extensions through those canaliculi, which are those little tunnels through which the cytoplasmic extensions travel, and they connect via gap junctions, which allows for the transfer of nutrients and ions and waste products from one osteocyte to the next. Osteocytes do not divide. However, if they are freed or released from their lacuna, they can differentiate into an osteoblast or an osteogenic cell. And if an osteoblast produces enough matrix that it encases itself within bone, it will differentiate into an osteocyte. So osteoblasts and osteocytes can differentiate into one another depending on if they are surrounded by bone or released from their bony encasement. Functions of osteocytes are to maintain the protein and mineral content of the matrix and help repair damaged bone. So the osteoblasts build the bone, and then the osteocytes maintain the bone. Osteoblasts are immature bone cells that secrete matrix compounds. That means that they are building bone, and the term for building bone is osteogenesis. That is the formation of new bone. Osteoid is the matrix produced by the osteoblasts that has not yet been calcified to form the bone. So osteoblasts create osteoid, and then the osteoid calcifies and forms the matrix of bone. Osteoblasts can build too much bone and surround themselves by bone and then differentiate into osteocytes. So osteoblasts are bone builders. Building of bone is osteogenesis. Osteoprogenitor cells are our mesenchymal cells. Mesenchymal are also called stem cells, and they divide to produce additional osteoblasts. We find osteoprogenitor cells in the endosteum, the inner lining of the bone, and the intercellular layer of the periosteum. So the periosteum is around the outside of bone, the endosteum lines the central canals. And so we find osteoprogenitor cells in the endosteum and the cellular layer of the periosteum. And osteoprogenitor cells are very active during fracture repair. When you break a bone, you need to build more bone to repair that fracture. And so osteoprogenitor cells make more osteoblasts than osteoblasts build more bone to repair in the fracture. Osteoclasts are those giant multinucleate cells. They secrete acids and protein digesting enzymes, and those acids and enzymes break down the bony matrix. And so it can release stored minerals. So if you have low blood calcium, you can break down some of your bone and release calcium out into the system and therefore increase your blood calcium again. So the breaking down of bone is termed osteolysis. Lysis is to break. So osteolysis is the breakdown of bone, and that is what osteoclasts do. Osteoclasts are derived from stem cells that produce macrophages, so they are different than the way that osteoblasts are, and osteocytes differentiate from osteoprogenitor cells. In order to maintain homeostasis of our skeletal system, the bone building by the osteoblasts and the bone breakdown by the osteoclasts have to be in balance. So you need to build bone at the same rate at which you're breaking down bone. If that doesn't happen, if you have more breakdown of bone than building of bone, you end up with weak or brittle bones. Exercise, particularly weight-bearing exercise, causes osteoblasts to build more bone. So when you have little old ladies who are getting osteoporotic and they want to maintain the bone that they have, a lot of times they're told to go exercise in a pool because it's easier for them, and that's all well and good, and it's great to stretch in a pool and makes your muscles feel good, but it's not going to help their bones because the pool takes away all of the gravity. So you need to have a weight-bearing exercise, which could just be walking, but you could walk with little, 1-pound weights in your hands or little 1-pound weights on your ankles, and that just increases the work that your skeletal system has to do, and so that's going to help maintain your bone density versus, lying on the ground and doing exercises like that, or being in a pool and exercising that is a non-weight bearing exercise. So compact bone, we're going to look at the difference between compact bone and spongy bone. So compact bone, you can see, is all of this out here, and then this in here is spongy bone. So right now we're going to talk about compact bone. So compact bone is made up of osteons. So the osteon is the basic building block of compact bone. And here you can see one osteon, another osteon. So the osteons are these round units of bone. They are made up of osteocytes that are arranged in what are called concentric lamellae. So the concentric lamellae are these layers of bone that wrap around this central canal. And the central canal is at the very center that has, you can see the little red artery and the little blue vein in the center there. So that is the central canal. Here you can see it nicely because it's cut in half, that the central canal is running up the center of the osteon, and it has an artery and a vein. And then the concentric lamellae are these little circles that are the layers that wrap around. So here we have 3 concentric lamellae. So they're the layers that are wrapping around that central canal. And you can see those little dark circles within those lamellae. Maybe I'll try this one here. So these little dark circles are the osteocytes. So we have the osteocytes arranged in concentric lamellae around the central canal. The perforating canal are the canals that go horizontally. So the central canals go lengthwise along the long bone, and the perforating canals go horizontally. So they're at a 90-degree angle from the central canals. And so they're bringing a blood supply from outside the bone here all the way into the trabecular or spongy bone on the inside of the marrow cavity. So we talked about concentric lamellae being the layers of the actual osteon surrounding the central canal. And then we also have circumferential lamellae, which are these layers that wrap around the outside of the entire bone. So when you're looking at the entire bone here, you've got circumferential lamellae around the outside, and then concentric lamellae making up the individual osteons, like that. So you have concentric lamellae and circumferential lamellae. And then, since you need more lamellae, the last thing that you have are called interstitial lamellae, and these are little layers that fill in the spaces between the osteons. So when you put all these round osteons together, you're bound to have spaces in between, and we can't just have air in the middle of bone because it doesn't work out well. So you have these little layers of bone in between the osteons, and those are called interstitial lamellae. So concentric lamellae in the osteon, interstitial lamellae between osteons, circumferential lamellae making up the circumference or the outer ring of the entire long bone. This is showing us the structure of the compact bone and how the collagen fibers are oriented. So here we've got 1, 2, 3 of the concentric lamellae, and you can see the osteocytes in the lacunae that are making up these concentric lamellae. But what I like about this is this bottom picture here, because it's showing you that the collagen fibers are arranged at a 45-degree angle, and that each lamellae has collagen fibers arranged at 90-degree angles to the lamellae that's next to it. So collagen, if you remember, resists stresses in one direction. So when pulled from end to end, collagen fibers are stronger than steel. So if you are stressing this bone in that direction, the stress is being mitigated by this layer and this layer. So that stress is, the collagen is resisting that stress in these two layers, but this middle layer is not resisting this stress at all. However, if you were to stress the bone in the opposite direction, then that middle layer is going to be resisting the stress. So this way, when you have torsion on a bone, there are, half of the bone is resisting torsion in one direction, and the other half of the bone is resisting torsion in the other direction. And so it makes this bone much stronger to all the different forces that could come at it. Spongy bone is oriented very differently than compact bone. So spongy bone, which is also called trabecular bone, does not have osteons. It is made up of a matrix of open network, which is called the trabeculae. So here you can see how it looks kind of like a spider web of bone in there, and that is trabecular bone, and you can see that pattern in here. So there are no blood vessels in the trabeculae, but the space in between those trabeculae is full of red bone marrow. And the red bone marrow has blood vessels, and that is where our red blood cells are created, is within red marrow. The marrow itself is going to supply nutrients to the osteocytes that are within these lamellae that make up the trabeculae. So we do still have osteocytes because we need to have osteoblasts and osteoclasts and osteocytes within the trabecular bone. And they are arranged concentrically here, but not in osteons that will be surrounding a central canal. All of the nutrients are coming through the canaliculi, which are the little openings into the trabeculae themselves. Some bones are full of yellow marrow, which is just fatty marrow, and it's just for fat storage, while other bones are full of red marrow where blood cell production is occurring. Here we're looking at the transfer of weight through the femur. So when you are standing, here you've got your pelvis sort of like this. We'll say like that. So the weight of your body is coming down like this, and it's pressing on the femur. And then you can see how the weight is transferred. So you've got compression on this medial side of the femur, and you have tension on the lateral side of the femur. And so this bone is resisting all of these different pressures in order to maintain the weight of your body and hold you upright. So tension on the lateral side, compression on the medial side. And you can see how that compression and tension is going through the cortical bone in the shaft of the bone, and then the compression spreads out through the trabecular bone in the distal epiphysis to allow for that articulation with the tibia underneath the femur down here. Okay, so let's look at the coverings of bone. So the outside of the bone, the total outer layer of the bone, is covered with a periosteum. The periosteum covers all bones except the parts that are enclosed within the joint capsule, and the joint capsule surrounds the joint itself. So the articulating cartilage is not covered by periosteum, but the rest of the bone is covered by a periosteum. The periosteum is made up of two layers, an outer layer, which is a fibrous layer that connects into the structures outside the bone, and then the inner layer, which is the cellular layer, which is where we find osteoblasts and osteoprogenitor cells. And so you can see here when it's pulled back, let's see, out here, you've got this inner cellular layer here, and then the outer fibrous layer there. There are also perforating fibers, which are being pointed out from here, and the perforating fibers are coming from the periosteum, and they're reaching into the bone here to really anchor that periosteum into the bone. They also fuse the periosteum with the joint capsule and also help to attach tendons and ligaments into the bone so that there are very, very tight attachments between those tendons and the ligaments and the joint capsule and the bone. Functions of periosteum is to isolate the bone from the surrounding tissues, provide a route for blood and nervous supply, and to participate in bone growth and repair through the osteoblasts and osteoprogenitor cells that we encounter there. Then there's also an endosteum. The endosteum is on the inside of bone. It is an incomplete cellular layer that lines the medullary cavity, which is also the marrow cavity, covers the trabeculae of spongy bone, so all of the spongy bone is covered with endosteum, lines the central canals where we have the blood vessels going up in the center of the osteons. And the endosteum contains osteoblasts, osteoprogenitor cells, and osteoclasts. So it's active in bone growth and repair. So when you have breakdown and rebuilding of bone, that's going to happen in and around the endosteum and the periosteum. Let's talk about bone formation and growth. So we know that when we're born, we're very small. We weigh about 7 pounds, and then we grow to be very large people over the course of anywhere from 12 to 25 years is our growth period. Osteogenesis is the term for bone formation. We talked about that earlier. And then ossification is the replacing of other tissues with bone. So our bones develop as a cartilage model, and then ossification turns that cartilage into bony tissue. So osteogenesis, bone formation. Ossification is the process of replacing other tissues with bone. Calcification is the deposition of calcium salts, and this occurs during ossification. And also other tissues can sometimes become calcified, and that's not a normal process, but it does sometimes occur. We have two main forms of ossification. One of them is intramembranous ossification, and the other is endochondral ossification. So we're going to look at those two methods individually. Endochondral ossification is where bone originates with a hyaline cartilage model, and this is how most of our bones originate. We're going to look at the 6 main steps that are involved in endochondral ossification. So first we have this cartilage model that occurs, and we have enlargement of the chondrocytes within the center of the model. This is going to soon begin to calcify, and the chondrocytes are going to enlarge and die and leave this cavity within our hyaline cartilage model. Step 2, we've got blood vessels here that are going to grow into the edges of the cartilage, and then it's going to bring cells of the perichondrium into the bone. Those cells are going to convert to osteoblasts, and then we're going to create this superficial bone layer around the edges of the cartilage model. Step 3, a blood vessel is going to penetrate into the center of the cartilage model. Fibroblasts are going to migrate along with that blood vessel and then differentiate into osteoblasts and begin producing spongy bone within the center of our cartilage model. So now we have this outer bone matrix, and we are also growing this inner bony region inside that model. Step 4, we're going to remodel this whole central area, creating a medullary cavity. So the bones of the shaft are going to become thicker, and the cartilage near each end of the epiphysis is replaced by shafts of bone. Step 5, arteries are going to enter each of the epiphyses and create a secondary ossification center. So this is our primary ossification center, and then these are our secondary ossification centers in each of the epiphyses. And then we're going to remodel the epiphyses so that we have a trabecular bone in the epiphysis, and we're going to make that cortical bone and spongy bone in the diaphysis. Notice that this articular cartilage here is the original cartilage from the hyaline model, the hyaline cartilage model, that does not differentiate into bone. So the keeping that articular cartilage is how our bones are going to seamlessly come together with very limited friction. And then this epiphyseal cartilage is at the metaphysis of the bone, and this is where our bone growth is going to occur throughout our lives until when we finally reach skeletal maturity between the ages of 18 and 25. That epiphysis is going to close and everything will ossify, and our bones will no longer be able to grow. So here we're looking at this metaphysis where you've got the bone growth happening. So these are your cartilage cells, and they are expanding and dividing. So that's the zone of proliferation where they are actively dividing and expanding. And then in the zone of hypertrophy, they are enlarging and then differentiating into osteoblasts. And here we have bony tissue being created. Appositional growth is where bones grow thicker and stronger by adding layers of those circumferential lamellae around the outside of the bone. Cells of the inner layer of the periosteum are going to differentiate into osteoblasts and create those additional circumferential lamellae. So osteoblasts are going to build bone and make the bone grow thicker, and that is appositional growth. Eventually, those osteoblasts are going to surround themselves in bone, at which time they're going to differentiate into osteoclasts. And the result of appositional growth is thicker, stronger bones. Next, we have what's called interstitial growth, and interstitial growth makes the bones grow longer. So bones grow at the epiphyseal plate. So it is a layer of hyaline cartilage that allows the diaphysis to grow in length but not in width. So interstitial growth is growing in length, appositional growth is growing in width. Epiphyseal lines are where once the long bones stop growing and the metaphysis closes and ossifies, we're left with epiphyseal lines. So the epiphyseal plate is the open metaphysis of a growing bone. The epiphyseal line is the closed ossified metaphysis where the diaphysis and the epiphysis come together. And these are visible on X-ray, and we'll look at a picture in a moment. As a long bone matures, the osteoclasts enlarge the medullary cavity, and the osteons form around the blood vessels and form that compact bone in the mature bone. So here's a picture. On the left, you can see the epiphyseal plates. So here there's an open epiphyseal plate here, and so they look almost like there's two bones that are not necessarily connected to each other. Bone looks white on X-ray, cartilage looks black, so these two pieces of bone are connected, but the cartilage is just showing up black, so this is where we see our epiphyseal plates. So this would be a child where the bones are not done growing. On the right, we have epiphyseal lines, so you can see these sort of white lines where those previous plates have grown together and ossified, leaving epiphyseal lines. So once you see an epiphyseal line on an X-ray, you know that this patient has reached skeletal maturity and their bones are no longer able to grow in length. So that was all a discussion about endochondral ossification. So we're going to do a short discussion on intramembranous ossification. So intramembranous is also called dermal ossification because it occurs within the dermis, which is a connective tissue, and it produces dermal bones. So dermal bones form within the dermis, so underneath the skin, and form bones such as the mandible, which is the lower part of the jaw, and the clavicle, which is the collarbone. The skull bones, I also believe, are dermal bones. So we have three main steps in intramembranous ossification. So first we have mesenchymal cells that are going to aggregate or come together and differentiate into osteoblasts and begin producing a bony matrix, begin ossification. The bone is going to expand in a series of what are called spicules. So here we can see spicules, which is where the bone is sort of reaching out and expanding through the dermis. These spicules are going to connect together and trap blood vessels within the bone. Over time, the bone is going to assume the structure of spongy bone and can later be remodeled and create these medullary cavities. Through remodeling, spongy bone formed can be converted to compact bone. So these dermal bones end up with a layer of compact bones surrounding this spongy bone. So that's our intramembranous ossification. Bones require a large blood supply. They also form our blood vessel or our blood cells. So we need a lot of veins to pull those blood cells back out of the bones. So we have three major sets of blood vessels supplying our bones. The nutrient artery and vein is a single pair of blood vessels that enter the diaphysis through a hole called the nutrient foramen. The femur is such a large bone that it has more than one pair of nutrient artery and veins. Most other bones have one single pair of a nutrient artery and a nutrient vein, and those are going to go in and supply. The arteries are bringing blood to the bones, and veins are draining blood away from the bones. Metaphyseal vessels supply the epiphyseal cartilage where bone growth is occurring. So our metaphyseal artery and vein are coming in at the metaphysis and supplying the epiphyseal cartilage. And then we have periosteal vessels, which are going to provide blood to the superficial osteons and the secondary ossification centers. So I'm trying to see if they're shown on here. They are not shown on here. Oh, actually, yes, they're in this periosteal arteries and veins in this little bump out here. So they are very small arteries that are supplying the periosteum and the superficial osteons. Periosteum also has a network of lymphatic vessels. Lymphatic vessels are collecting interstitial fluid, so fluid that is in between cells. Also, we have a lot of sensory nerves within our periosteum, so when we break a bone, it's extremely painful. The reason for that is because if it's painful, you're going to stop using it and allow for it to heal. If bone breaks were not painful, if you were to say break your ankle and it didn't hurt to walk on it, you would continue to walk on it and then it would heal inappropriately or not heal at all. So it's important that we have a lot of nervous innervation so that it's painful when we break our bones and lymphatics to drain all of the additional fluids. The remodeling of bone is happening all the time. So the adult skeleton is constantly replacing its mineral reserves by breaking down bone and building new bone. This process involves osteocytes to maintain bone, osteoblasts to build bone, and osteoclasts to break down bone. It is continually remodeling and replacing itself all the time. However, if the deposition of bone is greater than the removal of bone, your bones are going to get bigger and stronger. If the removal of bone is faster than the replacement of bone, your bones are going to get weaker. The more you exercise, the more you're going to build bone. Anytime you stress a bone, its reaction is to build more bone. So weight-bearing exercise is excellent in building nice, strong bones. But bone also degenerates quickly. So if you stop using it or you stop weight bearing, you can lose up to 1/3 of your bone mass in just a few weeks of inactivity. You can see this with people who have been in a cast. They're going to lose muscle tissue, but they're also going to lose bony tissue. So it's important to keep moving and weight bearing to keep your skeleton maintained at its optimal functioning. In order to grow and maintain our bones, we have a lot of nutritional factors that we need, and then there are some hormonal factors that come into play. So we need a dietary source of calcium. Our bones are mostly calcium, so we need to eat a lot of calcium. We also need phosphate salts, magnesium, fluoride, iron, and manganese in order to properly maintain our bones. Then there's a couple of hormones that are important. The hormone calcitriol is made in the kidneys, and it aids in the absorption of calcium and phosphorus from the digestive tract. So you can eat as much calcium as you want, but without calcitriol, you can't absorb the calcium. So calcitriol is very important, and the synthesis of calcitriol requires vitamin D3. So if you remember back to our last lecture, vitamin D3 is formed in the epidermis in the presence of UV radiation. So if you don't get out in the sun and you're not making enough vitamin D, then your kidneys can't create calcitriol, and then your intestinal system, your digestive system, cannot absorb calcium from what you're eating. So it's just a good way to see how all of our systems are interconnected with one another, that the integumentary system is very important to create the vitamin D to allow for the digestive system to absorb calcium, and then the calcium is going to be deposited into the skeletal system. We also need vitamin C for collagen synthesis and for osteoblast differentiation, vitamin A to stimulate osteoblast activity, and vitamins K and B12 to help synthesize bone proteins, such as the collagen fibers. Here are some hormonal effects, so you can look over this. It's just going to show you what the hormone is. So the hormones involved in the skeletal system are calcitriol, growth hormone, thyroxine, sex hormones, parathyroid hormone, and calcitonin. So we're going to look at calcium homeostasis. Calcium is super important throughout your entire body for a lot of different things, and so we need to have a stable level of calcium within our blood. Our calcium is stored within our bones along with other minerals, and it is the most abundant mineral in the body. Calcium ions are vital to membranes, so our cellular membranes and membrane transport, our functioning of our nervous system, and functioning and contraction of our muscle cells, especially our cardiac muscle cells. So if you want your heart to continue to beat, you need to have a dietary source of calcium and be able to pull calcium out of your bones and deposit calcium into your bones. Calcium regulation is very closely regulated, and it's regulated by two hormones, calcitonin and parathyroid hormone. And they control the storage of calcium, the absorption of calcium from the digestive system, and the excretion of calcium through the kidneys and in the urinary system. So they're affecting the bones where the calcium is stored, the digestive tract where calcium is absorbed, and the kidneys where calcium is excreted. Parathyroid hormone is produced by the parathyroid glands, which are little glands on the back of the thyroid glands in the neck. They increase blood calcium ion levels. So let's do that. Parathyroid hormone increases blood calcium ion levels by stimulating osteoclasts to break down bone and release calcium from the skeletal system, increasing the intestinal absorption of calcium. So you're going to absorb more calcium from the foods that you're eating under the influence of parathyroid hormone, and by decreasing excretion of calcium at the kidneys. So we're going to release calcium from bone, absorb more calcium in our intestines, and eliminate less calcium from our kidneys, all under the influence of parathyroid hormone. Calcitonin has the opposing effects. So calcitonin is secreted by the C cells or parafollicular cells within the thyroid gland, so also in your neck, very close. And calcitonin is going to decrease blood calcium ion levels by inhibiting osteoclast activity, which means you're not going to be releasing calcium, you're going to be storing more calcium in your bones, and by increasing excretion of calcium at the kidneys. So you're going to be releasing more calcium from the body and putting more calcium into the bones, and overall that's going to decrease the blood calcium levels. This picture shows the composition of bone. So we've got 1/3 organic compounds, which is mostly our collagen fibers, and then 2/3 minerals. Of the 2/3 minerals, just over 1/3 of it is calcium, and then the rest of it we have a large amount of phosphate, carbonate, and magnesium. So 67% inorganic, 33% organic. Calcium regulation. So here's just pictures of what we were just talking about. So parathyroid hormone is going to increase, here we are increasing blood calcium levels. So parathyroid hormone is going to stimulate osteoclasts to release calcium, which is going to go into the blood. It's going to stimulate the kidneys to retain calcium, so more calcium will go into the blood. And it is going to increase the rate of intestinal absorption. So you're going to absorb more calcium and send calcium into the blood. So parathyroid hormone, increasing blood calcium levels. Calcitonin has the opposite effect. So it's going to stimulate osteoblasts to put more calcium into the bone. Maybe I'll use a different color on this one. It's going to stimulate the loss of calcium at the kidneys, so that will decrease blood calcium levels. And it's going to decrease the rate of intestinal absorption, so that will decrease blood calcium levels overall. We're going to talk about fracture repair, and then we're going to look at some of the more common fractures. So fracture is a crack or a break in the bone, and it's caused by physical stress. Most people understand that. If you fall on an outstretched arm, you're likely to fracture your arm. It could be your radius or your ulna, or you could break your humerus, any of the bones in your arm. So when a fracture occurs, the first thing that happens is bleeding. There's lots of blood vessels in the bones, and so there's a lot of bleeding. And we produce a clot, which is called a fracture hematoma. So a fracture hematoma is a blood clot around the broken area of the bone. Within that clot, we establish a fibrous network. With blood clotting, you're going to learn more about it in A&P2. That fibrous network is from fibrin, which we find within the blood. And so that's going to sort of wall off that area, stop the bleeding, and the bone cells in that area are going to die. Secondly, the cells of the endosteum and the periosteum are going to migrate into the fracture zone and create a callus. And the callus is the beginnings of the restructuring of the bone. We have an external callus, which is cartilage and bone that surrounds the break, and then an internal callus which develops within the medullary cavity. So if the break goes all the way through the bone, we end up with an external callus and an internal callus. So let's look at then after that, osteoblasts are going to replace the central cartilage of the external callus with spongy bone. And then that bone is going to be remodeled by osteoblasts and osteoclasts for up to a year. That's going to decrease the callus and return the bone to more of a normal looking orientation. So let's look at some pictures. So step one, here we have a break in the bone and you can see that it's bleeding. So we have this fracture hematoma that forms, which is a big blood clot that forms around the bone. In step two, we've got cartilage beginning to be formed, and then some bony tissue is going to start to be formed within that callus. And this is our external callus out here and our internal callus in the medullary cavity. That callus is going to then be remodeled over the next year or so. And so in the beginning, you can see that there is this lump in the bone. So this callus formation actually is really helpful in diagnosing fracture. So if you fall and you have a hairline fracture that's not visible on X-ray, but the doctor thinks that you really did fracture it, you might have an X-ray the first day and it looks normal. So he might say, come back in a week or 5 or 6 days and let's X-ray this again. And that second X-ray, if you did fracture it, is going to show this callus formation. And so if you see that callus formation, you know that you did actually break that bone, and then they might want to cast you at that point. But it can take up to a year to remodel that bone back to looking like it's sort of normal bone. So here are some fractures. A Pott's fracture is a fracture of the ankle, and you can see that it's fractured both the tibia here and the fibula out there. So that's a painful fracture. Comminuted fracture is where a bone gets shattered. So here, this is the distal femur. We've got 1, 2, 3, 4, 5, at least 5, and this might be many more pieces. So this bone has been completely shattered and is going to need to be rebuilt and pinned together. Here's a transverse fracture, which is a fracture directly across a long bone, across the shaft of a long bone. So this bone is the ulna, this is the elbow, this is the head of the radius, this is the humerus, and this is the ulna. A spiral fracture is where you have a twisting fracture of a bone. So you can see that this bone has broken kind of on an angle there by twisting of the bone. This fracture is displaced, so you can see that it fractured right here, but then this part of the bone is projecting backwards. So for this to be, you might be able to manually reduce this, where you sort of pull apart this bone and that bone to get them to line back up before you cast it, or potentially you might have to go in surgically, line those up and pin them together in order to repair that fracture. This is a Colles fracture. This is what I was talking about, falling on an outstretched hand. In school, we called that a Fouche injury. That's an F. A Fouche is fall on outstretched hand. And so that is going to fracture the distal radius. So here that's a fracture of the distal radius where that arrow is pointing. This is a green stick fracture. Let's go back to here. So the green stick fracture is common in children who still have some more flexibility to their bone. So it's where you've just broken that outside of the bone and it doesn't go all the way through. This is a very dangerous fracture. So this is an epiphyseal fracture. So it's a fracture at the epiphyseal plate. So remember, the epiphyseal plate is the growth plate. So when you have a shearing, remember that growth plate is made up of cartilage. So it's easier to break cartilage than it is to break bone. So here you've got to go in and repair this, and it needs to be done quickly, because if you have a break at a growth plate and you don't repair it, then that bone is not going to end up growing at the same rate as the other bone. So if this happens in the legs, say in the distal femur like this, you could end up having one leg that's shorter than the other because that growth plate was interrupted in its growth process. This is a compression fracture. You can see that this vertebrae is nice and square, and this vertebrae looks nice and square. And so this vertebrae in between should be nice and square like that. But instead there was a compression, so you've got forces coming in either direction that squeezed and broke this vertebrae, and so now it's squished out and going in front and behind. These are often found in car accidents when you have a sudden stop and you sort of your upper body flings forward as the car stops, and so we compress. Also, if you were to say jump off of a roof and land on your feet, you can cause compression fractures. Yeah, things like that are going to cause these compression fractures. They also happen in people with osteoporosis. Your bone density decreases, so the strength of the bone decreases. So little old ladies who have that kind of hunchback appearance, they have multiple compression fractures within their spine where their vertebrae just sort of give out and compress. Osteopenia is the term for thinner, weaker bones. So when you begin to lose bone density, it's termed osteopenia. So osteopenia happens first. Number one is osteopenia. That early loss of bone density begins between ages 30 and 40. Women lose about 8% of their bone mass per decade, so every 10 years lose 8% of their bone mass. Men, you lose about 3% of their bone mass, and so this osteopenia is the precursor to osteoporosis. Osteopenia is typically in the epiphyses of long bones, in the vertebrae, and in the jaw or mandible. Results in fragile limbs, reduction of height, and tooth loss. In the mandible, your teeth are bound into the bone, so if you lose bone loss in your mandible, your teeth are going to start to fall out. Osteoporosis is number two. So after osteopenia, if osteopenia becomes severe, it turns into osteoporosis. So osteoporosis is where you have severe bone loss, affects your normal functioning, occurs over age 45 in about 29% of women and 18% of men. So this is where you get those multiple compression fractures in the spine. You're at much higher risk of bone breaks and decreased calcium reserves in your body. So on the left here, you have this normal bone that looks nice and smooth and beautiful. So this is trabecular bone. And on the left, I'm sorry, this is the left. On the right, this is osteoporotic bone. So you can see how that bone is just getting eaten away in there. And it looks like you could hold it in your hand and just crumple it, kind of like a big cheese doodle, right? That you can just kind of crush those. That's what osteoporotic bone looks like. So this is the end of our lecture for this week. I hope that you guys have an excellent week, and I'll see you back next week and as we begin our exploration of the axial skeleton.